Hello, everyone. Thank you for joining us today. I want to say a special thank you to the SAGE's leadership and support staff who have been able to pull off this wonderful meeting and still provide such great educational content in the face of these difficult times. I'd also like to thank Dr. Cobb and Dr. Augenstein for the opportunity to discuss the use of synthetic mesh in a contaminated field. These are my disclosures, none of which have any relevance to the current discussion. The repair of complex hernias in the setting of contamination or potential contamination presents a very difficult clinical scenario. The concern for doing a complex hernia repair in this setting is that there will ultimately be a mesh infection. Should the mesh become infected, traditional teaching would tell you that mesh removal is unfortunately necessary. And when mesh is removed, the inevitable hernia recurrence will ultimately result in yet another complex hernia repair. So, when we're considering using a permanent synthetic mesh in the setting of contamination, we really have to consider a few key things. First and foremost, what is the primary purpose or goal of the operation? Is this primarily a hernia repair, or is this patient having a fistula taken down, or an ostomy reversed, or a cancer removed? Second, does the mesh material and characteristics determine the clinical outcome? Third, what does the mesh location have to do with the clinical outcomes? And then finally, if you use a permanent synthetic mesh in a contaminated field and you develop a mesh infection, what are those potential consequences? When considering an abdominal wall reconstruction in the setting of another procedure, it is clear that the primary indication should always take precedence. You do not necessarily have to perform a Cadillac hernia repair in a definitive abdominal wall reconstruction. If you reverse a colostomy and have an anastomotic leak, it probably wouldn't be wise to go ahead with a complete abdominal wall reconstruction. If there's a cancer resection that is overly complicated with high blood loss or other complications, this may not be an ideal time for definitive reconstruction. When performing a hernia repair in the setting of contamination, it is really critical to understand the mesh materials that we're using and how those meshes may behave in different clinical scenarios. First of all, is there any appropriate mesh for use in a contaminated field? There are a lot of options to choose from permanent synthetic mesh made of PTFE, polypropylene, or polyester, absorbable synthetic meshes, and biologic meshes, which you've already heard much about this morning. From the standpoint of the FDA, there is no mesh that is currently approved for use in a contaminated field. It's really up to the surgeon then to understand the characteristics of the mesh and the biocompatibility. In other words, what is the mesh's ability to perform with the appropriate host response in a specific application. To understand this biocompatibility, we have to understand the construct of the mesh. Mesh is primarily made up of polymers woven together in a monofilament or a multifilament manner. This can result in pore sizes from incredibly microporous or even a laminar structure such as typical PTFE to a very large pore monofilament polypropylene mesh. These properties will affect how bacteria adhere to a given mesh, with a significantly higher bacterial adherence to small pore and laminar PTFE meshes and decreasing adherence with increased pore size. Similarly, the ability of a mesh material to clear a bacteria after inoculation also depends on the pore size, with smaller pore meshes unable to clear bacteria effectively and larger pore meshes able to clear bacterial infections more effectively. The structure can even affect the formation of biofilm, with a large pore polypropylene mesh better able to withstand biofilm formation even than a biologic mesh, at least in vitro studies. Large pore mesh seems to allow greater tissue ingrowth and neovascularization between the mesh fibers, allowing for a more effective host immune response. Aside from the characteristics of the mesh itself, probably the next most important technical consideration is the location of the mesh placement within the abdominal wall, as there are clear clinical differences between mesh placed in an onlay versus a retromuscular sublay versus an intraperitoneal underlay position. A meta-analysis comparing onlay to retromuscular sublay clearly demonstrates the benefit of sublay in terms of both infection and hernia recurrence. Another recent study comparing various positions of mesh placement within the abdominal wall concluded that a sublay retromuscular pair had the highest probability of being the best among the 4 possible treatments. Laboratory data is all fine and good, of course, but we practice in the real world, so what does the clinical data show? The use of biologic and absorbable synthetic mesh has already been discussed here, so I won't be presenting that data again here. I'd like to focus on our own experience with synthetic mesh in a contaminated field, as well as management of mesh infection with the remaining time that we have. I would, however, like to point out that we don't necessarily know how these biologic grafts behave in certain patients. As you can see here, this is a piece of non-cross-linked porcine acellular dermis that I removed from a patient more than 2 years after implantation. This looks very much like a piece of permanent PTFE. Yuri Nowitzki's group published a paper on biologic mesh explants, which demonstrated no evidence of tissue ingrowth, poor neovascularization, and poor remodeling. So we don't necessarily know how these meshes will behave in some of these contaminated settings. Our general practice is actually to use permanent synthetic mesh in most cases of contaminated hernia repair. We reviewed our recent experience with 540 total patients who were repaired in a contaminated setting with either clean contaminated, or dirty wounds. And as you can see, the vast majority of these patients were repaired with a permanent synthetic mesh. Most of these patients were fairly similar across groups with the exception of COPD, which was significantly higher in the absorbable synthetic and biologic mesh groups. We did also see a higher proportion of dirty and infected wounds repaired with biologic mesh and absorbable synthetic mesh compared to permanent synthetic mesh. We found that permanent synthetic mesh actually resulted in the lowest risk of surgical site infection compared to any other mesh type or even no mesh at all. To account for the differences between groups, we ran a multivariate analysis for surgical site infection. We found that COPD and a dirty wound conferred a higher risk of developing an SSI, but mesh selection actually did not confer any additional risk. The risk of hernia recurrence was also substantially reduced when using permanent synthetic mesh in these cases. There is a significant difference in terms of follow-up, however, and this may skew our results. To account for several of the variables often associated with hernia recurrence, we ran another multivariate analysis. We found that COPD, along with development of a postoperative SSI, conferred a significant increased risk of developing a hernia recurrence, but we found that permanent synthetic mesh significantly protected against the development of a hernia recurrence. Even though this study shows comparable outcomes in terms of SSI, and possibly even superior with a permanent synthetic mesh, as well as a definite benefit in terms of hernia recurrence, this still doesn't address what happens if a mesh infection actually occurs. What do you do post-op day 3 after a colostomy reversal and massive retromuscular incisional hernia repair when one of your drains suddenly turns bilious? What do you do when presented with a mesh infection from a previous intra-abdominal mesh after the subsequent abdominal operation? In our contaminated hernia repair study, we did have some mesh-related complications, though these were no more frequent in the permanent synthetic mesh group than they were the absorbable synthetic or biologic mesh group. We actually had several non-mesh related complications that required mesh removal, such as a colostomy disruption or a missed enterotomy, something that required a take back with an emergency laparotomy and essentially mesh removal in order to get back into the abdominal cavity to address the underlying pathology. In such a case with a potentially septic patient, it's rarely appropriate to spend additional time in the operating room replacing the mesh. We recently reviewed our experience of caring for patients with mesh infection, evaluating over 200 patients with chronic mesh infection presenting to our institution. We found that the location of the mesh within the abdominal wall and the characteristics of the mesh had a dramatic impact on our ability to salvage the mesh. As you can see here, when mesh was placed in an extraperitoneal position and was a macroporous monofilament polypropylene mesh, we were able to salvage this in over 70% of cases. Compare this to mesh placed in an intraperitoneal position, microporous mesh, multifilament polyester mesh, composite mesh, or PTFE mesh, which were very rarely able to be salvaged. So, should we be using synthetic mesh in a contaminated field? There are obviously some risks, as mentioned earlier. There is a definite risk of mesh infection in these cases, but I think we've been able to clearly show that the use of the proper mesh in the proper plane, specifically a monofilament large pore polypropylene mesh placed in an extraperitoneal position, ideally the retromuscular preperitoneal space, can be salvaged in the vast majority of cases, even in the event of infection. Combine these findings with the significantly lower cost of permanent synthetic mesh, along with the significant benefit in terms of hernia recurrence, and I think there is an excellent case for use of permanent synthetic mesh in the setting of contaminated hernia repair. Just don't forget that the primary indication for the procedure still must take precedence. If there are complications or some other concerns of the patient's overall condition at the time of the primary operation, primary closure and a staged repair or a simpler biologic or absorbable synthetic mesh repair is certainly a good option. And thank you very much for your attention.